Welcome, friends and supporters of the Wisconsin Association for Perinatal Care, aka WAPC, and its sister organization, the Perinatal Foundation, to our new podcast series. I'm Eva Fassbinder-Brummel, WAPC and Perinatal Foundation staff, and your host. Whether you be a physician, nurse, advanced practice nurse, nurse midwife, pharmacist, dietitian, social worker, public health professional, doula, doula trainer, childbirth or breastfeeding educator, advocate, or parent, all who support and care for women, newborns, and families during the perinatal period are welcome under the WAPC umbrella. WAPC is unique in that it is a multidisciplinary perinatal care association and one of the oldest in the country. For the first episode in our series, we feature an interview with Marie Walter on the topic of nitrous oxide use during labor, which we did at the 2016 WAPC annual conference. Marie is a lead educator for bereavement and advanced care planning services for Gunderson Medical Foundation in La Crosse, Wisconsin. Prior to that, she worked as a clinical nurse specialist in labor and delivery for many years. I was joined by guest interviewer and WAPC board member Amy Gilliland. Dr. Gilliland is an ASECT certified sexuality educator, a psychology instructor at Madison College, and is one of the first DONA International birth doula trainers. Her work has spanned the perinatal spectrum, and she has published research on birth doula support and female sexuality. Here's the interview. Enjoy.
Marie, less than a year ago, you instituted a protocol for the use of nitrous oxide at Gunderson Health Systems. And what was developing that program like for you?
Sure. I think I explained it today as it was a little bit like herding cats. That it sort of started out as not a real format of how we were going to do it. We have a collaborative practice committee that is on our unit that's very active and it's an interdisciplinary committee. And the subject was brought up there, and at that time I was the inpatient clinical nurse specialist, so it's not that bereavement services would be worried about nitrous oxide, but at that time I was the CNS for labor and delivery, and I agreed to take that role on. And it wasn't so much rocket science. It's pretty clear cut that there are certain steps you have to go through, but it was keeping the drum rolling and keeping people on task and saying, okay, let's get this done, and keeping people moving forward. So we started in February of last year and actually had a go-live date of June 24th last year. So it went pretty quickly.
Yeah, I was amazed when you said it was like less than 5 months.
Yes.
I mean, Gunderson in La Crosse has been doing innovative care for over 30 years. And
Yes.
I travel all over the state, and that's one of the things that I say, that people think things start in Madison because we've got a medical school, but
Right.
no, actually they almost always start in La Crosse, and then they
Thank
spread
you.
everywhere else.
Thank
So
you.
I wasn't surprised to hear about this innovation. What was the impetus for you in doing it?
Well, actually, several years ago, one of our obstetricians had come back from an ACOG meeting, and he said, well, I heard about this nitrous oxide making a resurgence, and it kind of fell on deaf ears, and people went, oh yeah, that's kind of interesting, and it disappeared. And then one of our nurse midwives, Amy Belling-Dunn, had expressed some interest in it, and then it came up at Collaborative Practice Committee, and we all agreed with the literature that's out there that it was really another nice thing to be able to offer labor patients as an option for pain management.
Yeah, and I think that putting the patients in the center is really what helps innovation to happen.
Right.
Now, in your presentation today, I think you mentioned that you thought of about 7 different stakeholders or interested
Yes.
people in the organization that you initially thought to involve, and then you ended up with a total of 14.
Right. There are some obvious people. You want some OBGYNs, and you really want a physician champion, somebody who's really solid with the idea, and that was Dr. Ken Merkich, and he was really very good in helping keep the department at large on board. Amy Belling-Dunn from the midwifery service. We had a family medicine physician because we have a handful of family medicine physicians who deliver babies. We wanted our nurse manager on board, obviously, for labor and delivery. We wanted a couple of labor and delivery RNs, certainly somebody from the anesthesia department, and then our nurse educator. And we were kind of the core group as we started out. But there were people didn't know existed in our institution, like the safety manager, that there's somebody who actually has a safety officer job, and so I should have included him. He came on a little bit later and was stellar in helping us prepare. Certainly pharmacy for any issues that we would have as far as storing some of the equipment and that sort of thing. The health unit coordinators or unit secretaries, because they're the ones who have to put the charges in and do all the details with that. And along with charges, it was the charge master analyst, who may have a different title in your organization, but she was the one who built the charges within the system so that we knew what to charge and how to trigger that charge. The logistics people for storage of tanks, where to put empty tanks, how to safely store them because they have to be a certain fire code. And then certainly the quality improvement nurse, because there are initiatives that should go on from there forward to make sure it's an effective program.
Mm-hmm. I think one of the assumptions that people make is that because it's a pain medication that would fall under the purview of anesthesia, but that's not the way it works.
No, and we tried to keep it as simple as possible because anesthesia was very upfront, and they said as long as you are at 50% blend, 50% nitrous, 50% oxygen or less, it is really analgesia. And we don't consult anesthesia for fentanyl or Nubane or any of the pain relieving medications we use. So they basically said, we're good with it. You know, this is fine. This is analgesia, and we incorporated it that way into our standing orders and into our documentation that it's under the pain relief flow, that it drop down box, nitrous began, drop down box, nitrous decede. So we tried to keep it as simple as possible.
And this is a much lower concentration that's used for dental procedures, right?
Dental procedures can be up to 80% nitrous and 20% oxygen, and it's a continuous flow, that little nasal cup that you get put on your, if you've ever used it in the dentist's office, and it can actually make you quite loopy. That's really where the laughing gas term came from. This is a 50-50 blend. And for anybody who's been through labor, rarely do you laugh through labor, and this will probably not change that perception either.
So what has the patient experience been like?
We've had some really good reports from patients. I actually worked with a mom who was having an external version where they were trying to rotate the baby from breech to head down. And we said, well, why don't we try this? And so just like in the videos that you will see, she started breathing the nitrous. When she relaxed, her hand fell away, so the mask came away from her face, and she was very relaxed. And then her eyes would pop open, and she would look to me, and she'd say, well, I can feel that. And I'd say, well, breathe again. She'd go, oh, that's right. And she'd put the mask back up. Totally relaxed during the whole procedure, never required any medications at all. So
Right, and it isn't really pain relief per se.
it's disassociation. The pain is still there, you just don't care about it. and there are women who use it for their entire labor. Some people would use it for an IV start or a difficult epidural start, or maybe a procedure afterwards if they're scared about the repair of an episiotomy. It's an anxiolytic, so it helps relieve anxiety, so it really helps people settle down as well.
Yeah. I think when you were talking about a manual exam afterwards, I think for that it's just really excellent. So
Right.
even if they haven't been using it before.
Sure, you've just passed a baby through there, and the thought of somebody pushing a hand in there to check things out is often very anxiety producing, and so it's a nice adjunct therapy.
And tell us, so women have to do the mask themselves, right? That's the rule?
There are some rules, and it's non-negotiable that a woman has to be able to hold the mask herself. No partner, no mother, no mother-in-law, no nurse can hold the mask for her, because when she gets relaxed enough, it will fall away. So there's not the risk of her getting too much nitrous. And there's no excuse for anyone else using the nitrous in the room either. Then it's taken from the room, never to return if that would happen.
Now, one of the surprising things had to do with epidural rates.
Right.
Because you had tell us about that. You had like 6 or 7 months of data on that?
Right, we have 6 or 7 months of, probably closer to 10 months now, but
Okay.
People said, well, this will definitely, you're doing this so you can decrease your epidural rate. That really was not in the plan. It was to offer patients another option for management of pain during labor. And most institutions who are currently using nitrous oxide will say it has very little effect on the epidural rate. And about 40% of women who start out with nitrous oxide will indeed go on to have an epidural. So in our data stayed pretty true to that we have about a 20 to 25% use of the nitrous during labor, and we still hover right around 45 to 50% epidurals. It's, and it goes up and down over the course of months, but it stayed pretty steady.
Yeah.
So, could I jump in and just
Yes.
clarify one thing? So, what is it without the nitrous, the epidural rate for women who try to birth, who intend to birth without epidural and then decide to have one? Is there a rate? Do you know the rate for that?
The overall epidural rate is 40 to
overall,
50% at our hospital.
Okay,
Yep,
so
yep.
it really didn't
And it didn't change it hardly at all.
Okay.
Yeah, I guess in my experience as a doula, for women who are intending to have an epidural, which happens for lots of different reasons
Correct.
besides just pain relief, that difficult period before they can get one or to establish labor progress, that to get through that hour and a half, that this would be a wonderful treatment for that.
It would be stellar because as a busy hospital, and we do about 1,600 deliveries a year, our anesthesia department is on call to everyone. And so you have multi-traumas or you have a cardiac issue that's going to the OR. We really go down the list of priorities for a labor epidural. And so we can say it's going to be a half an hour, 45 minutes, or an hour before anesthesia can arrive. Here's something you can try to get you through this next 45 minutes or so. And sometimes they like it so well they don't even ask for the epidural. So, and that's fine. They may later.
Now, that naturally begs the question about what about IV pain meds? Has it had, do you have any data on how it's affected the use of those?
We don't, and that's actually why we brought the QI nurse on board, is to start looking at other ways to look at the success of this program. And probably one of the biggest things we've looked at is the epidural versus the nitrous rate and the incredible amount of money that it saves. It's much, much less expensive from a patient perspective to have nitrous oxide than it is for an epidural, because the epidural involves other people, other staff. Plus, there are medications, you have to have an IV, you're limited to your bed most often, and so there's more interventions that way. Sometimes you have to have a bladder catheter because you can't empty your bladder. Where with nitrous, you don't have to have an IV, you don't have to have continuous fetal heart rate monitoring, you can be up and ambulating. It's much less invasive.
Yeah, to me, I mean, being able to do all those positions rather than with an epidural when you're always jerry-rigging with the peanut ball and stuff like that, that for her to be up and moving and to,
On the
and to have
birthing
that
ball,
cross.
in the tub, in the rocker, walking around, whatever works for her. If you have the right system, she can use the nitrous during all of that.
Right, without all of the side effects that show up with neurologically for the baby later on, yes.
right.
So even, so, well, thank you for doing this and for
Absolutely.
paving the way.
Absolutely.
For-
We're very excited to be the first in the state of Wisconsin to
Yes.
institute it. There will be others to follow, I'm sure.
Yes, we heard about some of this today, and so thank you on behalf of all the mothers and babies whose birth experiences you've improved.
Thank you.
Thank you.